Dear friends and colleagues, the Central European Cooperative Oncology Group, CCOG, of which the president I am, and my name is Christoph Zielinski, is proud to present to you today a webinar on post-ESMO breast cancer insights. This webinar has been organized in order to present to you the most important news on breast cancer which have been presented during ESMO, which means that we're covering immunotherapies, we're covering endocrine treatments, and we're covering not only metastatic disease, but also early breast cancer in the adjuvant setting. It's my particular pleasure to have gathered an excellent faculty consisting of Rupert Bach, Peter Fasching, Ahmed Awada, and Christian Singer. These persons, whom you all know, are gathered here to bring to you the most up-to-date news on breast cancer treatment in the year 2020. I want to thank Eli Lilly for supporting us to make this event possible, and also want to thank the CCOG staff, Ms. Fischer, Mr. Dietrich, and Dr. Teilinger for making this event technically and organization-wise possible. We're living all in challenging times, which have to be overcome by ingenious ideas and by a very strong commitment of the scientific community to deliver to our patients the best possible care, despite of challenges that we have to surmount and which the patients are confronted with. Within this context, once again, a very warm welcome and a very interesting afternoon, which will start now with a presentation by Professor Rupert Bach on immune checkpoint inhibition metastatic breast cancer. Does the chemotherapy backbone matter? And this refers to different presentations which were done in the ESMO annual meeting. And I'm sure he will put this into a context which will make you understand why one treatment works while the other does not. Rupert, please. Thank you very much for joining us.
Thank you so much for the invitation. Actually, that is a very challenging task. Explaining why some chemotherapies do work while others don't is not easy today because our understanding is not so knowledgeable about where we really stand. Immune checkpoint inhibition metastatic breast cancer, does the chemotherapy backbone matter? These are my disclosures. Chemotherapy has been with us for a while now, and in 1946, Gilman and Phillips already published in Nature the cytotoxic properties of nitrogen mustards, and in the 1970s, CMF, Jenny Bonadonna's CMF, was perhaps the first globally successful adjuvant chemotherapy regimen. The 1980s saw the introduction of anthracyclines into the adjuvant setting, and from the early 2000s onwards, the taxanes also were introduced in the neoadjuvant and adjuvant setting. And we have seen with these novel classes of drugs a gradual improvement of chemotherapy activity and a reduction of breast cancer specific and overall mortality. From our traditional point of view, these drugs are cytotoxics. So the main activity of these drugs is eventually the killing of cancer cells, and alkylating agents such as cyclophosphamide add alkyl groups to the DNA and therefore block DNA replication. Anthracyclines cause DNA intercalation, so they fit in between DNA base pairs and therefore prevent RNA and DNA synthesis. Platinum compounds lead to cross-linking of DNA strands, again inhibiting DNA replication, while taxanes stabilize the microtubule apparatus and therefore inhibit mitosis. More recently, our take on cancer has shifted from growth towards immunological mechanisms, and the main focus of the last years in research, of course, was immunotherapy. Now, immunotherapy seems to be very new to breast cancer. However, immunotherapy, truly successful immunotherapy, has been with us for a while now. Just think of trastuzumab, which is perhaps passive immunotherapy, but still highly active immunotherapy by the activation of ADCC and a HER2-specific T-cell response. It is really in the last years that the T-cells have more and more turned into the focus of interest. And under optimal circumstances, T-cells can prevent cancer outgrowth. Dendritic cells are able to identify cancer neoantigens, present them to T-cells, lead to T-cell activations, T-cell infiltrate the tumor microenvironment, destroy cancer cells, lead to a liberation of further antigens and to successful disease control. That, of course, does not always work because there are a couple of co-repressing molecules as well. But before we concentrate on this CTLA-4 and PD-1, PD-L1 story, we need to go back to the chemotherapy backbone for a moment. So, as outlined, traditionally, chemotherapeutic agents are understood as cytotoxic, which have as a side effect also immunosuppressive properties. But keeping that in mind, we might also see a depletion of regulatory T cells, which of course would be good. And there is also a chance for the regrowth of new population of pre-T cells, which could basically identify cancer cells as well. And there is another thing. Does chemotherapy always cause non-immunologic cell death, which does not cause dendritic cell activation? And there seems to be a chance that maturation of dendritic cells can be induced by immunogenic cell death, also caused by cytotoxics. One protein that plays a major role there is calreticulin. In case of immunologic cell death, there is a translocation of calreticulin to the cell surface in the pre-apoptotic phase. And as you can see here, after incubation with doxorubicin for 4 hours, there is an upregulation of CRT in the cell membrane, while this was not the cause with drugs not causing immunogenic cell death, such as etoposide or mitomycin C. In addition, mice were tumor-free if more calreticulin was seen after treatment with chemotherapy in the cell membrane of cancer cells. And again, that is especially true for drugs such as doxorubicin or mitoxantrone up here, while it's not caused by other drugs known not to cause immunogenic cell death. Today, and this is a beautiful review by Bracci et al., today it is known that many of our chemotherapeutic agents have specific immunologic properties as well. But if we concentrate for a moment only on the drugs we are commonly using in breast cancer, we see that cyclophosphamide results in a depletion of regulatory T cells. Anthracyclines induce immunogenic cell death and increase thereby dendritic cell antigen presentation. Carboplatin and cisplatin also decrease the concentration of regulatory T cells, increase cytotoxic T cells, and taxane also decrease regulatory T cells, increase the number of natural killer cells, cytotoxic T cells, and T cell infiltration. Now moving now to active immunotherapy, checkpoint inhibitors in breast cancer. And as you all know, of course, this is a relatively new development. The development of checkpoint inhibitors in breast cancer lags behind melanoma or lung cancer. The first trial conducted in breast cancer patients, KEYNOTE-012, was a basket trial including 32 patients with triple-negative breast cancer, PD-L1 positive, heavily pretreated, and lower response rate just below 20% was seen. And this typical effect of immunotherapy, activity only in a relatively small proportion of patients, but a prolonged disease control where activity is seen. Then, of course, KEYNOTE-086, single-arm phase 2 trial, gained triple-negative breast cancer, 2 cohorts, one of pre-treated patients and a first-line cohort. And again, something that is quite typical for the treatment with IOs in breast cancer was observed here. activity is much higher in earlier treatment lines, and PD-L1, at least in metastatic breast cancer, is as an important predictive biomarker. Now, of course, we would usually use chemotherapy in metastatic triple-negative breast cancer, and it's therefore somewhat logical to combine chemotherapy with immunotherapy. That was a phase 1b trial combining nab-paclitaxel plus atezolizumab. And I don't think that nab-paclitaxel was chosen here because of any ideas about the immunologic properties, just because it's a taxane that does not require corticosteroid co-medication. And in fact, relatively high response rates were observed, especially in the first-line treatment. Of course, it's being a phase 1b trial, so bias is possible here. But that eventually led to the development of the IMpassion 130 trial, which again led to the approval of atezolizumab for first-line treatment for PD-L1 positive metastatic triple-negative breast cancer. Large phase 3 trial, over 900 patients with triple-negative disease, randomized to nab-paclitaxel with either atezolizumab or placebo. And as you all know, and you have seen these results repeatedly in the overall population, a statistical significant, but well, not very exciting prolongation of progression-free survival, a much greater effect in the PD-L1 positive subset, a statistically not significant improvement of overall survival, again, in the all-comer population, while in PD-L1 positive patients, there was a significant and clinically relevant prolongation of overall survival seen. And that data were updated at the Esmo 2020 meeting again, indicating that with the combination of atezolizumab and nab-paclitaxel, you can increase overall survival to beyond 2 years in a population of patients which had a very poor prognosis before. Of course, if we compare that to HER2 positive or luminal breast cancer with survival in excess of 5 years observed today, these numbers are still very poor, but it is clearly shown that immunotherapy has activity here and that outcome of patients is slowly improving. Please be reminded, due to the hierarchical statistical analysis, formally the OS data in the PD-L1 positive population was not statistically significant, but as they are highly clinically relevant, these data led to the approval of the combination. 2/3 of the patients, of course, had received prior neoadjuvant or adjuvant therapy, and half of them had received prior taxanes, and it was very reassuring to see that prior taxane treatment had no negative effect on the outcome, on the activity of nab-paclitaxel plus atezolizumab. KEYNOTE 355 presented at the virtual ASCO meeting this year. Very similar design, first-line population, metastatic triple-negative breast cancer, more than 800 patients. 2 major differences, however. Chemotherapy backbone, not only nab-paclitaxel was possible, but also paclitaxel and carboplatin gemcitabine. And second difference, also patients with a disease-free interval in between 6 and 12 months were allowed on the trial. Patients were randomized to placebo or pembrolizumab plus chemotherapy. Half of the patients received gemcitabine carboplatin, and about a quarter of the patients had a very short disease-free interval, which is typical for triple-negative breast cancer with poor response to neoadjuvant chemotherapy. Primary endpoint in the patient population with PD-L1 positivity with a CPS score of 10 or larger. There was a statistically significant and clinically relevant prolongation of progression-free survival seen by about 4 months, numerically so also in CPS 1 or larger and in the overall population. When we concentrate for a moment on the patient subgroups, what we see is that it appears in CPS 10 or larger that the patients with a very short disease-free interval may derive less benefit from combination of chemotherapy with pembrolizumab, and also the effect of taxanes seem to be larger, that's up here. as compared to carboplatin gemcitabine. But please bear in mind that the majority of these early relapsers, relapsing early after neoadjuvant or adjuvant taxanes, might also have received gemcitabine carboplatin. The other hand side, we should be a little bit careful with this interpretation because the confidence intervals are completely overlapping, and in the subset of patients with CPS 1 or larger, this effect is not seen in a similar way. So early data, and there is another problem here. We don't really know how large the proportion of patients was who received nab-paclitaxel or conventional paclitaxel on the trial. There have been rumors that about 70% have received nab-paclitaxel, but there was no separate analysis of these two groups performed. Why is that important? Well, we have seen data from the Miles at the Esmo meeting regarding IMpassion 131. So we go back to atezolizumab, and this is a trial which is very similar to IMpassion 130. Again, metastatic triple-negative breast cancer patients, 650 patients randomized to conventional paclitaxel, either with placebo and atezolizumab. And if anybody would have asked me before, I would have said, well, the results will be pretty much the same as with nab-paclitaxel in IMpassion 130. And to a big surprise, there was absolutely no benefit seen in the ITT population as well as in the PD-L1 positive population with regards to progression-free survival and overall survival as well. So what is happening here? Is it subtle difference in between the two trials, with the trial populations? Is it due to the fact that corticosteroids are required as co-medication for paclitaxel? Is it just a game of chance because the confidence intervals of the outcome analysis, of course, are overlapping as well? What about the combination of pembrolizumab and conventional paclitaxel, as we have seen in the KEYNOTE trial? There we don't have the data, of course, but is there perhaps a difference in between pembrolizumab and atezolizumab, which may explain these reasons? Personally, I would feel the most probable reason really is the chemotherapy backbone, and I need to go now into the neoadjuvant setting for a moment. KEYNOTE 522 is a large phase 3 trial evaluating the role of pembrolizumab when added to carboplatin paclitaxel, followed by doxorubicin cyclophosphamide in the neoadjuvant setting. Co-primary endpoint, PCR, and event-free survival. And again, you all know these results, of course. A statistically significant and clinically relevant increase of PCR rates from 51 to 65%. PD-L1 just as a prognostic marker, not as a predictive marker here. And if we go to the forest plots here, again, with all due caution, it appears that the benefit is more pronounced if you add carboplatin in a weekly manner. And it appears that weekly carboplatin is rather immunomodulatory, while 3-weekly carboplatin has more immunosuppressive effects. So obviously the chemotherapy backbone really matters here. Moving on to another neoadjuvant trial, which data have been presented at the Esmo 2020 meeting, and that was IMpassion 031. So again, an IMpassion trial, again atezolizumab, but now in the neoadjuvant setting, nab-paclitaxel followed by AC. So kind of Gepacepto style regimen, either with atezolizumab or placebo. PCR is primary endpoint, 300 patients included here. And as you know, a statistically significant and clinically relevant increase of PCR with a delta of 16%. Again, progression-free survival, there was event-free survival and overall survival with a trend towards improvement with atezolizumab, but these are very early data. Also, PD-L1 status was again prognostic, not predictive. So also patients with PD-L1 negative tumors derive benefit from the addition of immunotherapy. So obviously, here we have again a very clearly positive trial with the addition of atezolizumab to nab-paclitaxel, and that kind of contradict the NEO-TRIP data. And these data have already been presented by Luca Gianni at the 2019 San Antonio meeting. Very intense chemotherapy regimen consisting of 8 cycles of nab-paclitaxel plus carboplatin, day 1-8 of a 3-weekly interval, followed by surgery, followed again by 4 cycles of anthracycline-based chemotherapy. And if you look at the PCR rates, there was absolutely no difference seen either in the ITT population nor in the PD-L1 positive population. So that brings up the question, is that the design, the endpoint wrong, the chemotherapy backbone wrong, which is definitely possible with that regimen? Perhaps too much chemotherapy or the wrong chemotherapy without anthracyclines and cyclophosphamide in the neoadjuvant setting, which seem to have an effect, as outlined before, on regulatory T cells. Still very hypothetical, I agree, but obviously we need to design very clever trials, asking the right questions, what backbone we should use for IOs in breast cancer. If we turn for a moment to other drugs beside chemotherapy, we can see that drugs such as tamoxifen and everolimus have rather immunosuppressive properties, while quite surprisingly, non-steroidal AIs decrease the concentration of regulatory T cells, and of course, bevacizumab also is a very potent immune modulatory substance, resulting in a conversion of M2 into M1 macrophages and increased T cell infiltration of the tumor microenvironment. Another class of drug which might be very interesting here in increasing the immunogenicity of our breast cancer the tumors is abemaciclib, a CDK4/6 inhibitor. And we have seen with the use of CDK4/6 inhibitors an increase in intracellular levels of double-stranded DNA and therefore an antiviral response, immune response, resulting in the inhibition of regulatory T cells and an increase in interferon production and antigen presentation. So it might make sense to combine immunotherapies with CDK4/6 inhibitors, and indeed one phase 1b trial has been performed, abemaciclib with pembrolizumab, and well, very early data, of course, just phase 1b data, but it appears that the combination might be more active than the CDK4/6 inhibitor alone. But of course, we will eventually need randomized trials here. So, in order to make a very long story short, we have learned that chemotherapy has properties beyond its cytotoxic activities. It's also active in terms of immunogenic effects. The combination of atezolizumab and nab-paclitaxel for the first-line treatment of PD-L1 positive metastatic triple-negative breast cancer remains the standard of care. The activity has not been seen in combination with conventional paclitaxel, either due to differential drug effects or perhaps due to the fact that conventional paclitaxel requires glucocorticosteroid co-medication. PD-L1 expression is important in metastatic breast cancer, less so in the early setting. So in neoadjuvant treatment, it's not predictive. IO plus chemotherapy definitely is superior to IO alone in breast cancer. The fact that there is a differential effect of differential chemotherapy regimen might be also mirrored by the neoadjuvant pembrolizumab data, where less effect was seen if carboplatin is administered 3 weekly. And of course, there is a wide field for combination with other targeted agents, and I would just like to remember the ultimate trial by Fabrice André, where the combination of IO with different other agents is tested in order to increase the immunogenicity of luminal breast cancer. So we have a feeling that we can increase the immunogenicity of disease with using the right combination partner for IOs. We don't really know what the optimal combination partner is at the moment, neither in triple-negative breast cancer nor in luminal breast cancer, and therefore cleverly designed further clinical trials are required, and I think the way it's being done in the ultimate trial is definitely an excellent approach. And with that, I leave you, and thank you very much for your attention.
Thank you very much, Wilfried. This was excellent and a wonderful review of the existing situation and of the current state of art concerning immunotherapy and or chemotherapy. The only question that there is which I find quite interesting, and that is that nab-paclitaxel, of course, is a completely different pharmacodynamic profile than paclitaxel does, due to its NAP component. So the question was whether paclitaxel would have a similar effect if, for it's given in a weekly way or in a way which would be given more frequently than, like, for instance, every 3 weeks.
Fully agree with you. Nab-paclitaxel is different from paclitaxel, and that might be the reason why the outcomes in the two trials has been different. It's not a slow release type of drug like we have with pegylated liposomal doxorubicin, but it appears as if, due to the special pharmacokinetic profile, the immunogenic effects might be different. With conventional paclitaxel, it might also make more sense to give it in a 3-weekly method. But again, the problem is we know that weekly paclitaxel is less toxic, more active than 3-weekly, and therefore it makes absolute sense to use the weekly. Have made absolute sense to use the weekly way in the IMpassion 131 trial. So I can't really imagine using a 3-weekly paclitaxel as a chemotherapy backbone for a clinical trial design at the moment.
Okay, thank you very much. So this is helps, I think, a lot in the understanding, and concerning the questions that we have, we're now coming to the end of this presentation, and I want to thank you very, very much, Robert, for having taken the time and having taken the effort to be with us today. Thank you very much. All the best. So our next presentation, where we are going to, will be given by Professor Peter Fasching, who again needs no introduction, and who will talk on how to increase the efficacy of anti-endocrine treatment of breast cancer, on options and limitations. I want again to thank you, Professor Fasching, for being part of this CECOG initiative, and it is your very high level of being famous in the world, which lends a lot of importance to this webinar. Thank you very much.
Thank you very much for the nice introduction. Thank you. I just thought I'd come here because I thought the Academy is a good initiative, but you're right, it's being transmitted out to the world. So hello everybody who's listening. You already heard very interesting data about immuno-oncology. Another field that kind of in the first few years secretly developed to be a field where lots and lots of improvement has been made is the anti-endocrine treatment and how to overcome endocrine resistance. These are my conflicts of interest. And I think everybody of you is aware of that in the treatment of patients with hormone receptor positive disease, this principle that was recently again confirmed in the ABC guidelines, and I'm sure in almost every national and international guideline you will find this, that the endocrine therapy is the preferred option for all hormone receptor positive HER2 negative patients who have an advanced disease. And you shouldn't give a chemotherapy unless all anti-endocrine therapies are exhausted. or the patient has a visceral crisis, and there's been some discussion about what that is. But nevertheless, this is the treatment principle. Hormone therapy until chemotherapy becomes necessary. And there's quite some development over the last 20, 30 years. And I tried to summarize this in this slide, where you can see that a very, very long time ago, tamoxifen was approved for the treatment of advanced breast cancer. But then during the 1990s, in the metastatic setting, these are the red boxes here, the aromatase inhibitors, anastrozole, letrozole, and exemestane came into the field. And then later on, all of these substances with the green boxes, indicated with the green boxes here, are being used for the treatment of the early breast cancer setting as well. Later on, combination therapies, about which I will talk a little bit more in detail today, came into play, which are everolimus, an mTOR inhibitor, palbociclib, ribociclib, and abemaciclib. Later on, also now reported at Esmo in the early breast cancer setting with abemaciclib and palbociclib. So what did we actually do in the past, having in mind that you should give not chemotherapy? So there is some data from a registry from Germany where we have looked, what are preferred treatment sequences for patients under 50 years, 50 to 65 years, and over 65 years. And this is like the charts, what is most popular, what do people do? And there you can see, knowing that you should give in the advanced therapy setting endocrine therapy for patients under 50, it's chemotherapy, then chemotherapy, and then chemotherapy again. And for the patients 50 to 65 years old, most popular was, until a few years ago, chemotherapy, 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 and only in the elderly population, being older than 65 years old, we did what the guidelines already set for some years, namely anti-hormonal treatment, anti-hormonal treatment, and anti-hormonal treatment, being the most popular treatment regime for patients with advanced hormone receptor positive HER2 negative disease. And maybe, even in the clinical setting, we doctors did not think it works well enough, because after the introduction of the CDK4/6 inhibitors, what you can see here in yellow, the most substantial part of the patients now is being treated first line, at least, with an anti-hormonal treatment-based therapy. In the second year after the approval, only 9.5% of the patients received still an endocrine monotherapy, and the chemotherapy use went down from 42% to 27%. So what happened here? Why are doctors now more convinced that an endocrine treatment makes sense? Well, we learned about what is endocrine resistance. And I mean, the cell has become quite complicated. And this is just a mere picture about the pathways that have been examined a lot in the context of endocrine resistance, because endocrine resistance is real. If you think back 10, 12 years ago, this is an example for a patient population after progression under an aromatase inhibitor in the metastatic setting. And there, a trial that was called the EFFECT trial examined a novel, at that time novel, endocrine therapy, the fulvestrant, with exemestane, a slightly different aromatase inhibitor to the previous therapies in the patient population. And what you can basically see here, both therapies do not work. So you have basically a population that is endocrine therapy resistant. And I always compare this to a waterfall. This is like waterfall-like progressions within the first 6 to 9 weeks. Half of the population, half of the patients, had a progression under a hormonal treatment. So we have to learn, or we had to learn, what are the resistance mechanisms and how can we overcome them? And one of the first trials that actually showed us that here, again, in the placebo arm, these waterfall-like progressions, like in the first few weeks, like almost half of the patients progress. And you get the feeling that with the addition of the drug everolimus, which is an mTOR inhibitor, you actually had a chance for at least some of these patients to overcome this endocrine resistance. And now we learn even more about all these pathways and the genes that might play a role. And it's now almost 20 years after the complete publication of the human genome. So there's lots of hints, actually, that we learned over the last 10 years. And this is an article from Nature about 10 years ago that I like a lot, because the National Institute of Health actually gave, the doctors, they put them on duty that now we know all the genes. We actually have to discover what's going on with the treatments. And I think we didn't do that bad over the last 10 years, because looking at endocrine resistance, I mean, where do we feel comfortable? Down here, we classify the tumors in triple negative, HER2 positive, luminal B, and luminal A, but all of this is connected. We do know that these expression profiles are mainly influenced by what's going on in the genes. Mutations in the tumor or amplifications, copy number variations play a large role in breast cancer. For patient genetics, we do know that patients that are born with a BRCA mutation in the germline, BRCA1, most of those develop actually a triple negative tumor. So all of these things are connected. So going for amplifications, almost 10 years ago, there was a landmark publication by Christina Curtis and collaborators who looked at where in the genome are the spots where gene expression is actually associated with gene amplification. And satisfyingly, HER2 was the strongest signal. So this was discovered in the 80s, that this is a very important gene for breast cancer. So if they wouldn't have discovered it, I mean, it would have been discovered later because it's the strongest signal. But also, cyclin D1 is one of the genes of the cell cycle where you also have amplifications that actually transfer into prognosis, and pointing out how important cell cycle, specifically in high proliferative hormone receptor positive tumors, are. And a drug that is well known to you that plays a big role in that are the CDK4/6 inhibitors. There's 3 of them, and in many, many trials that have been conducted, you see very similar pictures, namely again that hormone therapy resistance can be overcome by adding a CDK4/6 inhibitor to an endocrine monotherapy, and not only for progression-free survival, but also in 2 trials with ribociclib and in 1 trial with abemaciclib, a significant benefit for overall survival. So there's been lots and lots of trials conducted in that setting, the Mona Lisa trials, the Monarch trials, the Paloma trials, but all of them actually showed very similar effects with regard to progression-free survival, and also with regard to overall survival, where it has been reported. We're still waiting for the results concerning overall survival, concerning the patients that have been treated in the first-line setting that have generally a favorable prognosis. Obviously, these trials needed a little bit longer time to get there. So as we know, every treatment that is effective in the metastatic setting, we try to move to the adjuvant setting to reach as many patients as possible. And recently, 1 successful study has been reported with abemaciclib at the Esmo meeting this year, which was the Monarch E study. And here, patients with a high risk early breast cancer that were hormone receptor positive, HER2 negative, could be included, and they had to have a high risk for recurrence, defined as either having larger or equal 4 positive lymph nodes, or 1 to 3 positive lymph nodes, and then having a tumor size larger than 5 centimeters, having a histological grade of 3, or having a Ki-67 that is equal or larger 20%. These patients were randomized to a treatment of 2 years of abemaciclib plus the standard care endocrine therapy to standard care endocrine therapy as of physician's choice. And the results that were seen were statistically significant. The hazard ratio with regard to invasive disease-free survival was 0.75 about, with a p-value of 0.0096. And this transferred into 3.5% absolute difference between the 2 randomization arms. And this effect was quite consistent among the subgroups in the trial, where you can see that this effect doesn't seem to be dependent on the factors that were analyzed. Grading 1 was a very small subgroup, so there's wide confidence intervals. But I wouldn't be surprised if this stays like that. But nevertheless, it looks like a very consistent effect. So there you go with regard to a signal that was in the science sector, seen as a strong signal in a genome-wide approach, transfers not only into a treatment benefit for metastatic patients, but with the abemaciclib in the Monarch E study also in the adjuvant setting. Another example are mutations in the tumor. We do know, because there's been an effort called the Cancer Genome Atlas, which are the most frequently mutated genes in the tumors on the way from a normal breast epithelial cell to a breast cancer cell. So we do know that from the Cancer Genome Atlas, where they compared normal cells with tumor cells and looked for all the genes where there was a difference between the normal status and the tumor, and therefore we know which genes are most commonly mutated in these breast cancer tumors. And one of the genes of interest is the PI3 kinase subunit PIK3CA, which was mutated in 46% of the luminal A tumors, 32% of the luminal B tumors, and 39% of the HER2 positives. While the basal-likes in clinical setting, the triple negatives, didn't seem to have a high mutation rate in that gene. However, it makes it important or interesting, especially for the hormone receptor positive subgroup. So is there clinical relevance? Yes, there is. So from retrospective studies and other randomized trials that have been recently conducted, we do know that a mutation in the PI3 kinase might lead to a more unfavorable prognosis if this pathway is activated by a mutation. And because the PI3 kinase pathway plays such a central role in the cell, mainly transmitting the signal that comes from the receptors in the cell membrane, communicating with the outside world, transferring or transmitting that signal to the transcription factors and the network of factors that are downstream in the cell signaling, leading to survival, transformation, apoptosis, and growth, the PI3 kinase pathway is a very, very important pathway to address. Interestingly, this gene has several hotspots where mutations can occur. So diagnostics seem to be feasible in clinical practice because there's not an unlimited number of mutation sites in this gene if you want to cover more than 80 or 90% of the mutations in these genes. And the recent success of the drug alpelisib, about which I will briefly talk after this, is not unpredicted because other PI3 kinase inhibitors were tested before, like the bupalisib, which is a pan-PI3 kinase inhibitor, but had a side effect profile, so this drug couldn't be developed further clinically. Now you have isoform-specific PI3 kinase inhibitors that are more specific, have a more distinct safety profile because they only address certain isoforms, like the alpelisib addresses the alpha isoform of the PI3 kinase and therefore has a slightly different side effect profile. The SOLAR-1 study was presented already 2 years ago at Esmo, and this is how we want these trials to be conducted. 2 cohorts, a mutated cohort with mutations in the tumor and a cohort with no mutations in the tumor. And preferably what you want to see is that without mutation, the addition of the drug does not work, to spare these patients the side effects, and have the biomarker identify the group of people where the alpelisib would work. And in this trial, per randomization arm in a mutant cohort, about 170 patients were included, and the non-mutant cohort, about 115 patients. And these patients were patients that had a progression after a prior use of an aromatase inhibitor. So the results have been, as I said, presented already 2 years ago, and exactly what you want to see was seen, namely that in the mutated cohort, you would see a treatment benefit with a hazard ratio of 0.65, and in the non-mutated cohort, this difference was statistically not significant, and you can clearly see that these Kaplan-Meier curves lie together much more closely. So the question at that time was, would this work after a CDK4/6 inhibitor? And there was a small cohort that indicated yes. And this was already, although a very, very small subgroup of patients, so this needed further confirmation. Now at ESMO, the overall survival results of that study were presented, and this analysis did not achieve statistical significance, although you can see that numerically the alpelisib added to fulvestrant led to a median difference in median overall survival of 7.9 months, but this analysis was statistically not significant. Looking in subgroups of patients, it seemed that the effect in patients with visceral metastasis was a little bit larger, and you have numerically a larger difference in median overall survival of 14.4 months. But again, the analysis, the confidence interval hit the 1, and therefore it didn't achieve any statistical significance, although this was a subgroup analysis. Therefore, it's questionable whether p-values make sense after all. Nevertheless, time to subsequent chemotherapy was delayed by 8 to 9 months, and this was statistically significant. So another benefit for this treatment, regardless of the overall survival benefit and overall survival analysis. A few more words about something completely different. So changing the subject, because on the horizon there is some other ideas that can be used for the treatment of hormone receptor positive patients, not only hormone receptor positives, but also triple negatives. And this comes out of the world of antibody. So if you talk about antibody tuning, we know TDM1 is approved in the treatment of HER2 positive disease, which is an ADC, an antibody drug conjugate, which means there is a payload, a chemotherapy linked to the antibody, binding to the target, being internalized into the cell, and then the chemotherapy is released. So you have a very high concentration and a good efficacy in the cell. But you can modify this antibody on so many different levels. And as you can see here, this is the linker between the antibody and the chemotherapy. And this can be designed in different ways. So it could be designed weak, it could be designed very strong. And this would have an effect on how the payload, how the chemotherapy is delivered. So imagine that you have a very weak linker, then the payload would be easily released in the environment of the tumor cell. But if it's very strongly bound to the antibody, it's being internalized together with the antibody which has to be degraded. The chemotherapy works intracellular. So you could imagine if you would have an antibody that works a little bit differently, that would only use the target on the cell surface as an anchor, that the drug payload could be released in the environment and also work on tumor cells that don't have this target. So here there's a simulation of a HER2 heterogeneous tumor. You have HER2 positive tumor cells, HER2 negative tumor cells. And administering, for example, TDM1 with a very strong linker, it kills the HER2 positive cells, but you can see still plenty of cells, plenty of breast cancer cells that are left, while giving another ADC, now known as trastuzumab deruxtecan, for example, all the breast cancer cells are addressed and treated by this and being released into the environment. This has been shown to be effective in an early breast cancer trial, where you get a first impression about the efficacy, where not only HER2 positive breast cancer patients were included, but also patients that are HER2 negative, how we use the definition today. So they have some kind of HER2 expression, but they would be considered HER2 negative today if we classify our patients into hormone receptor positive, HER2 negative, or even triple negative. But if there is some kind of HER2 on the cell surface, in this trial it was shown here on the upper right part of the presentation that even if you have HER2 negative tumors with a low expression of HER2, you get a high response to this antibody drug conjugate, which opens a completely new perspective how to treat hormone receptor positive, now HER2 negative, but in future may be called HER2 low expressors. Still a matter of clinical investigation to treat with a different approach. So over the last 2 decades, we have at least 3 substance classes that overcome endocrine resistance that we can use in clinical practice. It's approved in most countries on this planet with the PI3 kinase inhibitors, the CDK4/6 inhibitors, and already a little bit longer the mTOR inhibitors. And recently learned that there's even more innovative approaches, not even addressing the endocrine pathway, but just using some targets on the cell surface to treat tumor cells that previously were thought, for example, to be HER2 negative, but have some kind of target on the cell surface. But by new treatment approaches like ADCs, they become available as patients for these treatments. And last not least, I haven't talked a lot about this, but you already heard from Professor Bartsch, the combination of endocrine treatments in immuno-oncology. This was specifically part of Rupert Bartsch's presentation, so that's something I didn't address in my presentation, but obviously this field is moving forward as well. However, with triple negatives being the main focus for the immune therapies right now, it might be not in the focus for quite some time. Thank you for your attention. That was it from my side so far.
Right. So thank you very much for this very comprehensive overview of new and upcoming treatment options for the treatment of breast cancer. Now, there is a question, of course, which is a logical one. If you would have several treatment options in a similar patient population, which one would you choose? Would you go for PI3K? Would you go for CDK4/6? Or would you go for everolimus? Which one would you, and what would the cascade be?
Excellent. So, of course, with the CDK4/6 inhibitors, the data is the most comprehensive, and we do know that we have trials with ribociclib and abemaciclib leading to an overall survival benefit. So this is the undisputed standard in the first-line therapy setting. And then, of course, it's important during that time to prepare for the next step. If you have a PI3 kinase mutation, you will have to find out at latest at the next progression. In some countries, the label for the drug is difficult, and it's different in the United States that from Europe, but there's a clear signal that this therapy is effective after CDK4/6 inhibitors. So if there's a PI3 kinase mutation after the CDK4/6, I would go for the PI3 kinase inhibitor. Don't forget also to test for BRCA mutations, because we do have PARP inhibitors also for the hormone receptor positives. And then after that, there's pretty much no standard set, because the studies with everolimus have been conducted at a time where there was no CDK4/6 inhibitor, no PI3 kinase inhibitor, but it stays a valid therapy option. It is an effective treatment, and that might be further down the line. And obviously, most of the patients are going into chemotherapy at some point in the therapy sequence. Sure.
Now, there's another question which I think also is quite interesting, because there is this interesting thing when patients would have been on chemotherapy before the entire knowledge of CDK4/6 inhibition. Would you consider going back to anti-endocrine treatment plus CDK4/6 inhibition and abandoning chemotherapy, which the patient might have received in the meantime?
I'm sorry, can you repeat that? I didn't get it quite. I'm sorry.
Right. So does preceding chemotherapy change the schedule and change the sensitivity towards CDK4/6 inhibition as compared to CDK4/6 inhibition given before chemotherapy?
Oh yeah, so the question goes into both directions. Does CDK4/6 inhibition have an influence on chemotherapy efficacy, and have chemotherapy an influence on CDK4/6 inhibitor therapy? There have been some studies that have indicated there is no effect on that, but basically there's no prospective trial that has looked for that question. It's like, what is the sequence? How does CDK4/6 inhibition and chemotherapy influence each other? There are some trials that are randomizing chemotherapy against CDK4/6 inhibition, but they have not been reported either, to see which might be more effective in what therapy line. So we don't know that yet.
I think that is quite an interesting field, probably of testing. Would be interesting to look at that. All right, thank you very much. That were the questions that came in here. Thank you very much, Professor Fasching, for joining us. It was a splendid presentation, and all the best, and stay healthy. All the best.
Thank you. Thank you for having me. Bye-bye.
Bye-bye. The next speaker will be there for Professor Christian Singer from Vienna, Austria, who is a very well-known and very famous gynecologist dealing with breast cancer. And he will talk about a new topic which we are having to cover right now. And this is a switching gears to adjuvant treatment of breast cancer. Now, the Esmo annual meeting produced very important insights on how you can deal with adjuvant treatment in breast cancer. And I look very, very much forward, together with you, to hear Professor Singer's presentation on this very topic, which will be, of course, an introductory one, because afterwards we'll hear also what makes the difference more specifically within the Palace and the Monarchy trials. And then we will wrap the entire story up. So Professor Singer, it's your turn now. Thank you very much.
So we're going to start on a topic which is almost impossible to cover because there is such an abundance of new adjuvant therapies in early breast cancer. And what I'm going to do is I'm going to give you a brief overview on HER2-positive breast cancer and on a segment of triple-negative breast cancer, namely those that can be treated with PARP inhibitors. Rupert has already given you a very nice overview on immunotherapies in the metastatic setting and also in the adjuvant setting, so I'm not going to cover this. Let me first start with trastuzumab, the treatment of HER2 overexpressed breast cancers in the adjuvant and also, if you permit me, in the neoadjuvant setting. We all know that HER2 is overexpressed and amplified in about a fifth of all human breast cancer cases. And we do also know that HER2 expression is associated with a poor prognosis. But on the other hand, we now have the ability to target HER2 through antibodies. And by using these antibodies, we can profoundly improve tumor response and long-term outcome in breast cancer. Therefore, trastuzumab has become kind of a gold standard over the years. There's a second antibody called pertuzumab, which also addresses the HER2 receptor, but in addition also the EGFR, and is able to abrogate a signal transduction, particularly when combined with trastuzumab. We have this data from the neoadjuvant setting. You all are aware of the NeoSphere trial, in which different combinations of trastuzumab and docetaxel with or without pertuzumab have been tested. And you also know that the combination of trastuzumab and pertuzumab with docetaxel results in a PCR rate of more than 45% as compared to trastuzumab docetaxel alone with 29%. You combine both antibodies, omitting chemotherapy, you can still obtain PCR rates of more than 16%. So an interesting approach that has been looked at a bit more specific in triple-positive breast cancers in other trials. It is of importance that there is a particular subgroup, namely hormone receptor negative breast cancer cases, which do derive the most prominent benefit with PCR rates of up to 63%, whereas receptor positive, HER2 positive, so to speak, triple positive, do derive a smaller benefit in terms of PCR. Does that translate to a long-term outcome? Well, it doesn't really show that so profoundly. This is data we have from NeoSphere that show 5-year disease-free and PFS. We do see that there is numerical differences, but there is no significant difference in terms of statistical significance. This, of course, has led to the design of adjuvant trials, where we try to explore and exploit the double combination of trastuzumab and pertuzumab in the adjuvant setting as well. There is 2 different backbones that have been proposed and have been evaluated in the affinity trial setting, either anthracycline-based chemotherapy or non-anthracycline-based chemotherapy. And whereas both arms received trastuzumab, one arm always had the addition of pertuzumab in the neoadjuvant setting. This is the demographic and baseline disease characteristics indicating a very balanced group A and group B pertuzumab versus placebo. And what do we see in the long-term outcome? Well, in the ITT population, we see a borderline statistical significance, which is mainly driven by node-positive breast cancer. So it does make a lot of sense to offer this kind of treatment to patients who are node positive. And you can see that in absolute terms, invasive disease-free survival rate is 86.7 versus 89.9. That is not a lot, but there is a significant difference, and you do not see this significant difference in node-negative disease. Is there a subgroup in affinity that would derive a larger benefit, or is there subgroups that do not derive a benefit? But we don't really see this here. Side effect profile, I'm really not in a position to sort of speculate too much on this, because there's a lot of data out there, but in principle, we do not see any untoward side effects that were unexpected or that would hamper us not to use the addition of pertuzumab in node-positive early breast cancer. There is another drug which you are also probably aware of. It's called trastuzumab emtansine, or TDM1, or Kadcyla, as it is marketed in most countries. It is a very interesting drug, since it sort of simplifies the access of a very detrimental chemotherapy to the target, namely to HER2. It's basically a HER2-based antibody linked to chemotherapy. And there's a couple of trials that have investigated this kind of treatment in the advanced setting, but there is an important trial that's looked into TDM1 in the post-neoadjuvant setting in patients who have HER2-positive early breast cancer, and who did not derive a complete pathological remission subsequent to neoadjuvant chemotherapy. And those patients who had still had invasive disease in the surgical sample were randomized and either received Herceptin or the TDM1 drug. Again, both arms are balanced. Please note that these patients had already had neoadjuvant therapy. The vast majority, of course, had trastuzumab alone. Only a fifth or so had trastuzumab plus pertuzumab or another targeted therapy. So the vast majority really had neoadjuvant trastuzumab. And if we look at the endpoint, the primary endpoint, invasive disease-free survival in this group, we can see that there is a clear distinction between those who received TDM1 and those who received trastuzumab. We can see that this also translates to freedom from distant recurrence with a hazard ratio of 0.6. So there's a 40% improvement in distant recurrence. And there also is a trend towards an improved overall survival. So we can now safely offer patients who have not benefited from neoadjuvant HER2-based treatment to an extent that they would have received complete pathological remission with the exchange of trastuzumab to TDM1. Again, the subgroup analysis indicates that more or less all groups benefited equally. Side effect profile, not different from what we have seen in the metastatic setting. The side effects such as fatigue, nausea, and another couple of side effects which we already know are associated with TDM1 have been found here as well. So no exception from there. Where do we stand now? Is there new developments? Yes, there is. There's a couple of new drugs. And I think the most prominent of those is trastuzumab deruxtecan, TDXT. And TDXT is an ADC, which is composed of a humanized anti-HER2 antibody and a payload that is comprised of very toxic chemotherapy, a topoisomerase A1 inhibitor, which is sort of linked to the antibody through a cleavable linker, and the payload of TDXD is particularly high. There is a ratio of 1 antibody to 8 drug molecules. So you basically deliver a very high toxic drug load to the cell. And this really has shown remarkable results. This is the study portfolio of trastuzumab deruxtecan, which shows that it's moving forward from the late line setting to the early, even to the adjuvant setting. There is a trial out there now that investigates deruxtecan even in the adjuvant setting. Now, the data we have so far are from the advanced breast cancer setting, Destiny Breast 01, and you can see very nicely in this waterfall plot that almost all patients in a late line setting derived a significant and profound benefit from this drug. You can see a complete remission in 6%, a partial remission in 54%, in really severely pre-treated patients, a long duration of response, median duration of response is about 15 months, which is really remarkable. Median PFA of 16 months, something almost unheard of in this late line setting. With one exception, namely pneumonitis, the side effect profile is usually okay and acceptable and generally well manageable. However, we know that pneumonitis is one of those side effects that you have to account for and have to look into, particularly when offering deruxtecan in the adjuvant setting. And this really is the trial that's about to recruit, and that is already recruiting worldwide. Destiny 05, a substitution, if you wish, of TDM1 in the early setting in a particularly poor prognosis subgroup, either in patients who have primary inoperable disease or patients with a high risk of disease recurrence, namely pathologically positive axillary lymph nodes, and in patients who must not have had a complete pathological remission. They were going to be randomized 1-to-1 to receive either TDM1, which is sort of the standard of care nowadays in those patients who don't derive a good benefit from neoadjuvant chemotherapy, or trastuzumab deruxtecan for 14 cycles. I think quite an interesting study to look into. Switching topics now to another field in which substantial progress has been made over the last couple of years, that is the triple negative breast cancer setting. And triple negative really stands for those patients who do have BRCA mutations or gene repair deficiencies. And I'm going to detail this a little bit better, but we do know that the vast majority of patients are sporadic, but we know that in about 7 to 8% of breast cancer patients, we do see a germ limitations. And this percentage rises in triple negative breast cancer, where up to a fifth, more or less 18 to 20% of patients, particularly if they're young, have a BRCA mutation. So BRCA mutations nowadays need to be looked at in triple negative breast cancer, particularly if the patient is of a younger age. Why is it so important? Because we now have drugs that are really targeted at homologous recombination repair deficient tumors, and BRCA1 and BRCA2 deficient tumors are homologous repair deficient tumors. Normally, to explain the principle of action to you, normally cells are repaired by a very effective and efficient mechanism with high fidelity, which almost never makes a mistake when replication is being repaired, and that's a mechanism that's called homologous recombination, and BRCA1 and BRCA2, together with other genes, are responsible for this. If you lack homologous recombination, you basically have to rely on alternative repair mechanisms such as homologous and non-homologous end joining or single-strand annealing. And these repair mechanisms are way inferior to homologous recombination and cause a lot of defects and alterations and repair deficits, and cells tend to become malignant. We do think that this is one of the mechanisms how tumor cells derive. And if you now manage to impair and to abrogate the non-homologous recombination, BRCA deficient cell has no more means to repair its DNA double-strand breaks and has to die. And this pretty much is the mechanism how PARP inhibitors work. Let me explain this again. If you have a BRCA 1 or 2 germline mutation, you have one allele that is functioning and you have one allele that isn't functioning, you still are able to produce a functional protein, and you're still able to repair double-strand breaks because you do still have homologous recombination. Now, if one of the cells in the body, for instance, a breast cell, has what we call a loss of heterozygosity, which means becomes homologous now for a deficient BRCA gene. Because of a second hit, the functioning allele is now infunctional. Again, we do not have the possibility to produce a functional BRCA protein. And we only have these alternative repair mechanisms at hand, which causes tumor cells to arrive, but on the other hand, makes those tumor cells very sensible to the inhibition of these non-homologous repair mechanisms. And this is probably the way how PARP inhibitors function. A very complicated mechanism, but a very efficient mechanism. This is data that have been published a couple of years now ago. This is data from olaparib, one of the PARP inhibitors that's now widely used in the metastatic breast cancer setting. And it showed that monotherapy with olaparib has remarkable results. We know this from prostate cancer, where it has been state-of-the-art for many, many years. And we now also have data from the metastatic breast cancer setting. This is one of the 2 studies that has looked at the PARP inhibitor in BRCA mutated patients who have been treated with anthracyclines and taxanes before, who had no more than 2 chemotherapy lines prior to the use of the PARP inhibitor, and who were randomized 2-to-1 to receive either olaparib or chemotherapy of physician's choice. Primary endpoint in the Olympiad was progression-free survival, and secondary endpoints was overall survival response rates and other clinically meaningful endpoints. Primary endpoint, progression-free survival, remarkable difference, significant difference with a hazard ratio of 0.58. You can see that there is a median PFS of 4.2 months in the treatment of physician choice group versus 7 months in the olaparib group. This really is a tablet that you can now use instead of side effect prone chemotherapy. Overall survival, well, at this stage, there was no difference in the overall survival, but the study wasn't really powered for that, so we're not really concerned about this at this stage. Other endpoints, response rate and duration of response, again, significant differences with a partial response in 51% versus 27% in treatment of physician's choice. So really a good argument for the use of PARP inhibitors in patients with metastatic breast cancer who do have a germline BRCA mutation. The subgroup analysis also shows that there is no significant difference in terms of subgroups that are looked at. BRCA1 and BRCA2 don't seem to be different. Platinum-based treatment prior to the use of PARP inhibitors doesn't seem to make a difference. Receptor status doesn't really seem to make a difference. So overall, all groups benefit equally. An important endpoint to look at in the metastatic setting is, of course, quality of life, and the time to deterioration of quality of life scores has also been measured in these studies. And you can see that there is a longer time until the quality of life decreases if you offer a PARP inhibitor. You pay for it by having Side effects, that's the question. Well, not really. If you look into the side effect profile, grade 3 and more, anemia is an issue. Neutropenia is not so much of an issue because you're comparing to chemotherapy. So all in all, PARP inhibitors are well tolerated. Another study that has looked into a PARP inhibitor in the metastatic setting is EMBRACA. Similar design, similar setting, similar endpoints, similar results, increase in PFS with a hazard ratio of 0.32, which is remarkable in this setting, particularly here in this case with brain metastasis. So this is the only trial that has prospectively looked at brain metastasis in BRCA mutation carriers and the benefit of a PARP inhibitor here. Again, time to deterioration of quality of life is prolonged by using the PARP inhibitor, in this case talazoparib, and the median time until quality of life increases from 6 to 24 months, so remarkable. And of course, you try to push this into the neoadjuvant in the adjuvant setting. This is data from a very interesting neoadjuvant trial, a very small and early trial that has looked at one of the PARP inhibitors, namely talazoparib, in the neoadjuvant setting. And it simply looked at a fairly small number, admittedly, but tumors of more than 1 centimeter, stage 1 to 3, who had a proven BRCA 1 or 2 mutation and who were HER2 negative, received this treatment with 1 milligram orally per day. And look at that, you can achieve a PCR or RCB 0 and a near complete remission RCB 1 in 12 cases out of 20 cases. I think this is very, very encouraging data, and I hope we can see more on the use of PARP inhibitors. Again, side effect profile, this is a small study, so we're not really focusing on this too much, but we do see that the side effect profile resembles what we know from the metastatic setting. And it's, of course, is the reason for a large study that is currently ongoing, that has already completed recruitment, and it is, I think the database lock is in the coming 2 weeks or so, and we hope to see results early next year of an adjuvant treatment of our germline mutation carriers in BRCA1 and BRCA2 patients who receive olaparib twice daily for a year, or placebo twice daily or for a year, and we hope to have an increase in invasive disease-free survival. Watch out for this trial. I think it's very important. It will change the therapeutic and also the diagnostic algorithm if positive. There is another study that looked at PARP inhibitors in the neoadjuvant setting, and Peter Fasching has already presented data, and he's the principal investigator of this study, GEPAROLA, which looks into the use of PARP inhibitors in the neoadjuvant setting, 12 cycles of weekly paclitaxel in combination with olaparib versus carbotaxol, a classical treatment for triple negative breast cancers and also for ovarian cancer cases. The inclusion criterion was HRD, which is a very interesting concept. It basically is a tool or an algorithm, or if you wish, an analysis that is currently offered by Myriad Genetics, which looks into a score which indicates whether the tumor is inefficient to repair double-strand breaks. And this score is called HRD. And HR deficient tumors are being defined as tumors that have a score that is beyond a certain threshold. And those are made up of mutation carriers, of BRCA mutation carriers, but also of non-mutation carriers, which have if you wish, genomic genotype that is fairly similar to that of mutation carriers. An interesting study that basically looked at the PCR rate in patients treated with paclitaxel and olaparib, and the main object was not to compare it with the carbotaxol arm, but really to look into the probability of achieving a PCR. And you can see that you can achieve a PCR in this setting in more than half of the patients, and that it's interesting that you can see that you can achieve high PCR rates both in the mutated and the non-mutated population, provided they have HR deficiency. So I think HR deficiency really is a very interesting concept that needs to be evaluated further. Side effect profile of this particular therapy seems to be a bit better, but mind you that there is this is a fairly small number in this study. Now the question also arises: does it make sense? Whether it makes sense to combine PARP inhibitors with platinum-based treatment? This is very early preliminary and preclinical data in which patients, or actually clinical data, but very early data, in which patients have been treated with a platinum-based treatment and olaparib, and you see that the combination results in a better overall survival than the treatment with the platinum-based treatment alone or with the PARP inhibitor alone. And we have been using this concept in a study that is currently ongoing. It's an ABCSG study, Austrian breast and colorectal study, a cancer study group, where we use the same concept that Peter Fasching has used. We are looking at high HRD scores, also, however, in triple-negative breast cancer patients, and we randomize them 1-to-1 and offer them either carboplatin and olaparib or anthracycline or taxane-based treatment. There's a lot of translational work with it, and we hope to compare both arms and see whether the treatment with a PARP inhibitor in combination with platinum-based treatment is not only well tolerated, but also effective. With this very short overview and omitting everything that is related to immune therapy, I thank you very much for your attention.
Thank you very much. Thank you, Christian. This was great and an incredible overview of a real very quick and very comprehensive overview. Thanks a lot. Incredible work. Thank you very much. So, Christian, if you would say, in one sentence, what was the thing which impressed you most during the last 2 years in concerning advances in the treatment of early breast cancer? If you would tell me these things.
Impossible to say. I think
I know.
1E was remarkable. Immunotherapy was remarkable. I think that's the two topics that I would sort of point out.
Okay, thank you very much.
That's really
right. So considering immunotherapy, let's maybe go a little deeper, because the next talk will deal very much with CDK4/6 inhibition. But considering immunotherapy, why would you think is it that triple negatives are working so much better than other characteristics in breast cancer?
Yeah. If you look at genomic alterations by CGH arrays, for instance, you can see that there is an incredible number of, if you wish, mistakes that are being made within the cell, within the replication mechanism. So you do see a lot of genomic alterations, which subsequently are translated into neoantigens. So I think the neoantigen load is particularly high in triple-negative breast cancer, and it probably is one of the reasons why you have such a pro-immunogenic environment in particularly this subgroup, and this probably is one of the reasons why triple-negative breast cancers are prone for immunotherapy. Not that it wouldn't work in other tumors, but you can see such a variety of neoantigens. You basically stir up the immune system, and I think that's probably one of the reasons why it's so effective there.
Yeah, definitely is. But the question is also, I mean, we do have these results in PD-L1 positives, which are impressive. So do you think like other combinations with, I don't know, CDK4/6 inhibitors plus immunotherapy would be interesting, or other compound combinations, in order to have the entire population the ability to access?
Yeah. I think one of the interesting aspects is to combine CDK4/6 inhibitors with immunotherapy. And we've looked into this, and if you look into the fairly small trials, albeit that are available in the metastatic setting, you can see that there is a toxic component associated with this. Particularly, if I recall a poster that I saw at the last San Antonio meeting, looking into hepatotoxic side effects in combination of abemaciclib with nivolumab and pembrolizumab, I think. And particularly, if you combine abemaciclib, which has an immune response and it sort of triggers the immune system, with a immune therapy, you end up having significant and very common side effects. It's up to 10% or so of patients deriving liver hepatotoxicity. And I think this is not a way to go forward in the adjuvant setting. You might not even consider this in the metastatic setting. It's simply too toxic. So I'm a bit disappointed about these kind of combinations so far.
So we're stuck with the PD-L1s, with the PD-L1 overexpressors, right? But then, at any rate, it's a huge step forward, no doubt.
Honestly, we don't really know enough about that, because it's so surprising that in some trials, even the same drug with atezolizumab, you seem to have a benefit in PD-L1 positives, and then there's another group who doesn't benefit from PD-L1 positives. So there's a lot to be learned. We still don't really know how it functions, and PD-L1 might be a surrogate parameter. So I think there's much more work to be done.
Right. So thank you very much, Christian, once again, for this comprehensive and incredible overview of recent developments. Thanks a lot. And stay healthy and take care. You know, in Austria, coronavirus, to all the other listeners in Austria, coronavirus is quite heavily active. So we all have to be careful.
Stay home.
All the best, Christian. All the best. Ladies and gentlemen, dear friends, we're coming now to the talk by Professor Ahmed Awada. Professor Awada is definitely one of the most famous and brilliant oncologists from Europe. As you all know, he's coming from Brussels, Belgium. And Professor Awada is very, very much experienced with early trials, and we'll talk now about a very, very important aspect which was covered during the Esmo annual meeting. And these were two trials which were somewhat contradictory, the PALACE and the Monarch-E trial in the early breast cancer setting. So Ahmed, it's a pleasure to welcome you. Thank you very much to be present with us and to talk to us. Please be so kind and deliver your presentation. Thanks a lot, Ahmed. Thank you.
Thanks, Christoph, for this kind invitation. I'm really happy to participate to this really activity. And so you give me this challenging task to look to these two important studies reported recently, PALACE trial presented at the last Esmo and Monarch-E trial presented at last Esmo, as well reported in GCO. And so the aim of my talk is to try to summarize what makes the clinical difference between PALACE with palbociclib and Monarch-E trial with abemaciclib. So you can see here my disclosure. Let me start with a slide only to summarize what is really needed in clinical practice as prognostic and predictive marker to take the decision for any therapy, basically any systemic therapy in early breast cancer. You can see here for predictive, as predictive biomarker, clearly we have hormone receptor expression and HER2 amplification, and nothing else, in order to decide about anti-HER2 therapy from one side and or endocrine therapy from the other side. For chemotherapy, unfortunately, so far there are really no predictive biomarker of benefit to chemotherapy besides the gene profiling in some situation. And basically, all these parameters inside this circle are prognostic, and of course guide us to decide what is the optimal systemic therapy, adjuvant systemic therapy for our patient. Of course, there are the tumor size, which is really important, the nodal status, but here the question is 0 versus 1 to 3, more than 3. I think histology is important because we know that ductal carcinoma is compared, for example, to lobular carcinoma. Lobular, at least for endocrine therapy, seems preferable to go to aromatase inhibitor compared to tamoxifen. The age, you can discuss about the age, chronological, physiological, biological age, but really is important also in the decision process. The grade of the tumor, Ki67, a lot of study about Ki67 at all level, clinician, from the clinician point of view, pathological point of view, and finally lymphovascular invasion, and of course to the right but not the least, gene profiling in up to, let's say, 1 to 3 lymph node positive or more receptor positive with Taylor X trial and Manductor trial. So basically, this is the basis what we base to decide early adjuvant therapy or even neoadjuvant therapy, whenever the adjuvant therapy is endocrine therapy or chemotherapy. And before to go to PALACE and Monarch E trial, I think it's important to remember what are the recommendations today in terms of therapy for ER positive, HER2 negative early breast cancer. And that's really this slide, the 3 slides I will show you are adapted from the guidelines and recommendation reported in Annals of Oncology by our friend Giuseppe Crigliano. And it's really interesting because they subdivide this patient in 3 major groups. And I think this is really make a lot of sense. If we take a patient or more receptor positive with high expression for more receptor, small tumor at the maximum T1, pathological T1B, no lymph node, axillary lymph node, low proliferation, low grade, low genomic risk. Basically, this group of patients is luminal A disease. So in the premenopausal setting, simply we will give tamoxifen for 5 years. In the postmenopausal setting, we have the choice between tamoxifen and aromatase inhibitor for 5 years. If I have a lobular cancer, probably I will propose aromatase inhibitor. If the patient had, let's say, osteoporosis, I will go to tamoxifen. So basically here, endocrine therapy is the major therapy in the adjuvant setting. Now, if we go to the second group, which is really the most important but most difficult group in our clinical practice, always in ER positive, HER2 negative. High to intermediate or more receptor expression. Tumor type is less than 5 centimeters between T1C and T2, N0 to N3, and you can see here intermediate to high proliferation or grade, intermediate genomic risk. So this is really the group with a major difficulty in clinical practice. And our colleagues in the recommendation, and I agree with that, and this was really what used in our clinical practice here in Jules Bordet Institute in Brussels, of course, subdivided, of course, between premenopausal and postmenopausal. In the premenopausal setting, if we have this group of patients I showed here in the title of this slide, they basically all intermediate in terms of size, gene profiling, and so on. If we have a certain clinical risk, we cannot say really high here, pathological N0, intermediate genomic risk. Basically today, based on all the data available from gene profiling as well from randomized clinical trial, that we should offer to this group of patients with intermediate genomic risk ovarian function suppression plus tamoxifen for 5 or more years, or ovarian function suppression and exemestane. And chemotherapy is really reserved to selected cases, probably with high tumor size and so on. In the opposite, if we have intermediate to high clinical risk, that means if not positive, or intermediate to high genomic risk, so basically this patient premenopausal patient will receive, the majority will receive chemo, and after that OFS or OFS plus exemestane as alternative to therapy. Now, in the postmenopausal setting, for the same situation, in certain clinical risk, PN0, intermediate genomic risk, I think here, no doubt, aromatase inhibitor is upfront, is the optimal adjuvant therapy to propose, and chemotherapy to reserve very, I can say here, very selected cases. In the intermediate high clinical risk, and mainly in case of pathological lymph node axillary positive or intermediate high genomic risk, clearly these patients should receive both chemotherapy and aromatase inhibitor, and aromatase inhibitor more than 5 years according to the risk and tolerability. So I think this is really a complicated slide to some extent, but summarize really well how to approach patients with intermediate risk, intermediate genomic risk, in the premenopausal setting, postmenopausal setting, taken into consideration also other parameters to have uncertain or high, and to administer chemotherapy in addition to hormonal therapy. Basically, hormonal therapy and the maximum hormonal therapy, aromatase inhibitor upfront for postmenopausal, OFS plus exemestane for premenopausal. And now we have this group of patients with intermediate to low hormone receptor expression, more proliferative, high Ki67, intermediate to high genomic risk. In the premenopausal high risk, here we will go to chemotherapy and overall function suppression and aromatase inhibitor will give all what we have. And of course, OFS if premenopausal after chemotherapy. For postmenopausal high risk, we'll give chemotherapy and aromatase inhibitor alone. And for more than 5 years, hormonal therapy according to the risk, of course, and tolerability. So this is also to say up to PALAS and up to Monarch E, these are the recommendations and still used today in our clinical practice, and important to remember. Let's move now to Monarch E and PALAS study and to conclude. What is the conclusion today, at least from my point of view, based on available data and the median follow-up observed of these two trials? Remember the study characteristics. For the Monarch E trial, of course, the drug is abemaciclib, giving for 2 years with endocrine therapy, of course. And in the PALAS trial, palbociclib is the CDK4/6 inhibitor in combination with endocrine therapy. You can see here the inclusion period. Stratification factors are not so different. Here in the Monarch E trial, previous chemo, menopausal status, and region. In the PALAS trial, they stratify patients according to the stage of the disease, stage 2A versus 2B3, chemo, yes or not, age less than 50, more than 50, and the region. And here it's important to focus your attention in patient eligibility. In the Monarch E, you can see here, there are here inversion. In the Monarch E, the patient should have a lymph node positive more than 4 lymph node, or lymph node positive 1 to 3 plus one of these parameters. This is in the Monarch E. I am sorry for this inversion in this slide. So lymph node more than 4 lymph node positive, or lymph node positive 1 to 3 with one of these parameters, T more than 5 centimeters, or grade 3, or Ki67 more 20%. In the PALAS trial, is overall, they put stage 2 to 3 without any really subdivision. Statistics here, they look both for 85% for hazard ratio of 0.73 for Monarch E trial and 0.75 for PALAS trial, and they look to invasive disease-free survival as the main endpoint. For the interim analysis, they look here for 50% of required event, and for PALAS, they look for second futility at 313 events. So what about adjuvant therapy in the Monarch E and PALAS trial? About neoadjuvant or adjuvant chemotherapy, 95% of the patients in the Monarch E received adjuvant or neoadjuvant therapy, 82% in the PALAS trial. 30% in both trials received tamoxifen. Same percentage receives, around 70% receive aromatase inhibitor. In both trials, 20% received ovarian function suppression. We have the information for bone modifying agent in the Monarch E, 14%, and not available for PALLAS trial. What about CDK4/6 inhibitor exposure? Abemaciclib in the Monarch E trial and palbociclib in the PALLAS trial. Important to remember that the median follow-up in the Monarch E is still 15 months. And only 12% of patients completed 2-year treatment period. This is really very limited period of follow-up, and still many patients are on treatment. And that's really important to keep it in mind. In the PALLAS trial, the median follow-up is 24 months. You can see here the premature CDK4/6 inhibitor discontinuation, 16% in the Monarch E, but here the median follow-up is much limited than PALLAS. 42% of the patients discontinue prematurely CDK4/6 inhibitor, 2/3 due to adverse event in the PALLAS trial. You can see here 41% at this stage of the evaluation has dose reduction in general. 55% reduce palbo to level -1 at 24 months in the PALLAS trial, palbociclib, and 34% in addition to that to level -2 at 24 months. So there are more dose reduction in the PALLAS trial than in the Monarch E trial, taking into consideration that the median follow-up is much limited in the Monarch E compared to PALLAS trial. And now we have the main result from Monarch E with abemaciclib and palbociclib from PALLAS in the adjuvant setting. Remember the median follow-up here, and you can see the result of invasive disease-free survival at 2 years for abemaciclib plus endocrine therapy, 92.2%, versus 87% for endocrine therapy alone. You can see the hazard ratio here, 0.75, the confidence interval, and the p-value. Clearly, at this level, the study met its primary endpoint, but still at the limited median follow-up, and a huge number of patients still on therapy. In the opposite, for PALLAS trial, with the median follow-up of 23 months, you can see here the invasive disease-free survival is 88% for the combination of palbo endocrine therapy, 88.5% for endocrine therapy alone. Basically, sorry, the hazard ratio is 0.93, confidence interval, so there are no difference between both arms, and is negative trial. So we have the data at this time for Monarch E, IDFS, for PALLAS trial with the median follow-up reported here. So let's go now a little bit very quickly to subgroup analysis for IDFS. Basically, all subgroup in the Monarch E trial with abemaciclib seems to benefit. No really difference between all this group taken into consideration: region, menopausal status, baseline, ectodermal status, tumor stage. For PALLAS subgroup analysis, there are some difference. It seems that N0 benefited more than N1. Patient who didn't receive neoadjuvant or adjuvant chemotherapy more benefit than patient received adjuvant neoadjuvant chemotherapy, but it's important to consider this hypothesis generating. But it's important, nevertheless, to keep it in mind when we analyze the difference, because this is my task today at the end. It's important also to remember that in the PALLAS trial, 76% of events occur in the high-risk population. And high-risk population in the PALLAS trial is around 60%. In the opposite, in the monarchy trial, 100% of the patient was high-risk population. So in the PALAS study, 76% of events occur in high-risk population, which is around 60% of the whole population. And now raising the question about the relationship between here the high risk and sensitivity to CDK4/6 inhibitor. But that's, I will keep it for the discussion later on. So that is the main question to me today. Why do Monarch E and PALAS results differ? And going back to some important difference between Monarch E and PALAS. In Monarch E, in terms of selection of patient, 100% of the patient were high-risk population. More than 4 lymph node positive, or 1 to 3, with tumor type more than 5 centimeter, or grade 3, or Ki67 more than 20%. So basically, the extreme majority, nearly all patient, high-risk patient. In the PALAS trial, the selection, they take stage 2 and 3. That means the patient were less selected in terms of risk, but basically we can conclude, taking into consideration the lymph node and the size of the tumor, 60% only were high risk compared to 100% here. Abemaciclib is giving continuously. Abemaciclib is pan-CDK4/6 inhibitor and mainly CDK4 inhibitor than CDK6 inhibitor. In the opposite, Palbo is giving intermittently and mainly CDK6, more potent on CDK6 than on CDK4. And these are the differences. I'm not saying that these differences are responsible for this different effect, but it's important to mention and to keep it in mind. There are, of course, up to the time of the analysis, more CDK4/6 discontinuation in the PALAS trial, mainly to adverse event, more than 60% of the patient. And here we have 42% discontinuation rate compared to 17% for abemaciclib. Major difference too. CDK4/6 reduction, 41% in the Monarch E and 89% in the PALAS. So there are significant difference in terms of those reduction between the two studies. And finally, it's important also to mention for Monarch E, but unfortunately are not available from the presentation in the PALAS trial, that the site of recurrence, there are 30% in the bone and in the abemaciclib arm, and 53% in the endocrine therapy alone. And so this is really important because that means at least we are seeing less bone metastasis, a site of recurrence in the Monarch E at the time of analysis compared to endocrine therapy alone. And for visceral, there are some difference, but this difference is not so important. So we can say there are less bone recurrence at the time of Monarch E analysis with the combination of endocrine therapy and abema compared to endocrine therapy alone. Unfortunately, these data are not available to my knowledge for PALAS trial, at least from what was reported at Esmo. So that's from the two studies. But I would like to go back a little bit also to the data from advanced disease, because in advanced disease, the result from abemaciclib, palbociclib, randomized trial could give us some insight why in the adjuvant settings there are also the difference at least observed. Remember that in the abemaciclib studies, to my knowledge, the only drug so far showed activity by itself without combination with endocrine therapy is abema. In Monarch 1 trial, in heavily pretreated population, 40% of the patient developed clinical benefit rate. And so in heavily pretreated patients. So this drug, even without combination with endocrine therapy, is potent drug. But for Palbo, I didn't see data, solid data showing that this drug is active by itself. So there are here story of potency also, which could translate on activity. Even if the major data reported on the randomized trial in the advanced setting are not different in terms of hazard ratio, PFS so far. Interestingly enough, also to remember, from the advanced disease, the efficacy seen in endocrine therapy sensitive disease versus endocrine therapy resistant disease, in other terms, primary resistance versus secondary resistance, we saw from Monarch 2 trial that this drug, Abima, is effective in primary resistant tumor as well in primary and secondary resistance in both settings. In the opposite, palbociclib in subgroup analysis, the efficacy is mainly seen in endocrine therapy sensitive disease, at least in terms of overall survival. And particularly true also in patients with no prior chemotherapy, because palbociclib mainly if we take Paloma 2 trials, they took, and Paloma 3, sorry, they took patients less heavily pretreated, but also heavily pretreated patient. So there are some difference, at least in the advanced setting. Does this translate also in the adjuvant setting? Is hypothesis, but let's keep it in mind. And finally, the subgroup analysis was consistent in with abemaciclib in Monarch 2 and Monarch 3. Subgroup analysis showed that this drug abemaciclib, in addition to low-risk population, in high-risk advanced breast cancer, liver metastasis, low treatment-free interval, progesterone receptor negative, grade 3, this drug showed activity in whole population, but also in high-risk population of advanced disease. For palbo, there are some data, but are less clear. So there are differences in the two studies, but also we can extract some differences from the advanced setting and from the randomized trial. Is this explain, let's say, why the result of Abima, at least so far with the available data, seems to be positive and not with palbociclib? That is really a matter of discussion and still hypothesis at the level of the hypothesis. But it's important not to neglect also, we heard from press release, we don't have the data so far, also Penelope B trial of palbociclib in early breast cancer did not meet primary endpoint with IDFS. Remember, this trial took hormone receptor positive patient with invasive residual disease after completing neoadjuvant chemotherapy, randomized to palbo 1 year and endocrine therapy, placebo with endocrine therapy. So basically, this group should be considered as a high-risk patient because after neoadjuvant chemotherapy still had residual disease. And we know this patient, the prognosis of this patient is not so good. So, and this trial also is negative. So clearly, palbo in high-risk population seems not to be the optimal drug to be used for our patient. Now, there are a lot of unknown things here. There are some direction. From the discussion at Esmo, from the paper, I took this and I reported here. I'm really in, let's say, in agreement with that. Will improve IDFS will be translated in improved overall survival? Still, really very open question today. The question here, will CDK4/6 inhibition reduce late recurrence? And basically the question here is mainly for abemaciclib and Monarch E trials. I think if I should say something here at this time, I expecting yes, because abemaciclib work in high-risk population, high-risk group, but also in very sensitive population. Why not to have efficacy in late recurrence? That's mean endocrine sensitive population. So my answer here is possibly yes, but let's wait the result with longer follow-up, mainly 5 and more follow-up. What about long-term toxicity? That's still open question yet. But we have already experience in patient treated with CDK4/6 inhibitor and abemaciclib for 5-6 years now in the advanced setting and without major problem. And this, to me, at least reassuring. But of course, we'll see at the later and last with longer follow-up. For me, the optimal duration of therapy is still an open question. Here, okay, 2 years. Do we need 2 years of therapy? And there are also toxicity of this kind of therapy. We'll see if academic trials could answer this really important question. Remember, anti-HER2 therapy, trastuzumab, 2 years is not better than 1 year. And 1 year is standard of care, and there are some discussion about less than 1 year for some group of patients. So I think at the academic level, it's really, really important to study the optimal duration of CDK4/6 inhibitor, which are really, let's say, if I could summarize like that, more cytotoxic than cytostatic, the nature of endocrine therapy by the mechanism of action on cell cycle. Yeah, and this is really the important question for clinical practice. Is abemaciclib a standard of care in early breast cancer? I think, as Dr. Stich concluded, the decision to use adjuvant CDK4/6 inhibitor, and here abemaciclib, because we are speaking about monarch-E result therapy, this decision is complex. Then the result with median follow-up of 15 months of EDFS in this trial. I think overall survival data will be really important here and are awaited. I think we'll have more mature data of IDFS very soon, hopefully at San Antonio Breast Cancer Symposium or later, but during 2021. I think here the quality of life and patient-reported outcome are really important because we are very keen within the adjuvant setting with toxic drugs. And of course, the financial aspect is important for the access to this innovative therapy. But I think we can say with some confidence that the result of abemaciclib from the advanced disease setting and now the early setting, even if there are premature, in this high-risk population, for me, are very encouraging. And now I think the major question here, what will be the value of abemaciclib in less, let's say, much lesser risky patient? Of course, in the group of population studied in monarch-E is really around, let's say, 5 to 8% of our population in clinical practice. The major group is in the intermediate situation. And there, the question, what will be the value of CDK4/6 inhibitor as a whole, and in particular, abemaciclib in this group of patients? And with that, I would like to thank you very much for your kind attention.
Thank you very much, Ahmed, for this extremely reflective talk. I've learned a lot. Thank you very much. Now, a question probably that is popping up really is what do you think? I mean, is abemaciclib now standard of care in endocrine in the adjuvant treatment of endocrine responsive patients, or would you still think it's premature to say that? What would you say?
I think we'll have very soon, hopefully, more mature data of IDFS, and I expect we'll go in the same direction. If this is a question of some months, and if this continue to going in the same direction, and I expect will be the case, I think we should start to discuss with our patients this option, because they took a group of patients really at high risk of early recurrence. When we have more than 4 lymph node positive, when we have 1 to 3, but tumor size more than 5 centimeters, grade 3. So this group of patients are at risk of early recurrence. And so it's important to offer this patient very quickly the best therapy in order to avoid, let's say, recurrence. Because once metastatic breast cancer, we know we are not curative.
Sure. And considering the length of administration, what will you say? Because, I mean, I just remember very well still the anti-endocrine treatment trials. You remember them probably as well, 1 year, 2 year, 5 years. So the design that you would right now do is 2 years versus 5 years, or rather 2 years versus 1 year?
You mean the next study? If I would like to do a next study, you know, of course, we should study 1 versus 2, but we are thinking another kind of study to answer the question. You know, of course, here they took high-risk population, and for high-risk population, let's go with what they did. But I think it's important to see what is the value of abemaciclib, because here the monarch E is positive. For ribociclib, we cannot say anything today. My proposition is, you know, there are true, in my opinion, there are two group of patients in intermediate risk population. A group they don't need at all CDK4/6 inhibitor. A group they need chemo and eventually hormone therapy and CDK4/6 inhibitor, and possibly there are a group they don't need chemo but CDK4/6 inhibitor. And our task as academic researcher to do a study to try to answer this question. So my proposition is to take intermediate risk population, to give them 1 month of endocrine therapy alone, to have the Ki67 before and at 4 weeks.
Right. So that's the Ki67 story, right? That was
not only for the first, let's say,
right.
Filter. And if Ki67 will go to less than 3%, probably this patient with endocrine therapy alone is enough. If this patient at 4 weeks Ki67 is more than 3%, I will do a gene profiling. For high-risk population, here I will randomize chemo versus endocrine therapy plus abemaciclib. For low risk at genomic level, I will go to hormone therapy plus CDK4/6 inhibitor. So I think this study will tell us, in my opinion, and we are thinking about it. We have already a synopsis for that. Who will need only endocrine therapy? Who will need chemo? And who will need CDK4/6 inhibitor and no chemo?
Very interesting. Very interesting. Yeah, that's probably it.
And
right?
Let's say the enrichment of the population in 2 steps. The first step will be by Ki67, and we'll ask to have less than 3% in order to continue endocrine therapy alone in the neoadjuvant setting. But for the other, to do gene profiling and to randomize.
So if CECO can help you in the recruitment of patients in Central and Southeastern Europe, we're happy to do so.
Okay.
If you're interested, great, let's fly together. Excellent. Thank you very much, Ahmed.
You're welcome. Thanks for the invitation.
Thank you for this magnificent talk. And ladies and gentlemen and dear friends, we have now arrived at the end of this November webinar of the post-ESMO annual meeting on the breast cancer. And I think we had 4 splendid lectures which showed us the real advances that have been made in the treatment of metastatic breast cancer and the early breast cancer, including immunotherapies, including antibody therapies and HER2 positives, and other HER2 expressing patients. And finally, in CDK4/6 inhibition, in addition to anti-endocrine treatments. So I think we've, in contrast to very many years in the past, we've made enormous advances in the treatment of breast cancer, which really should benefit our patients. So thank you very much for your attention. I once again want to thank the faculty, which was really delivering splendid talks. I want to thank Eli Lilly, which sponsored this event and made it possible. And finally, once again, I want to thank the CECOG staff for having facilitated this. Thank you very much, all the best, and make sure to be with us, and we will go for the post-San Antonio meeting in January, and please make sure to be present with us as well and accompany us on this very interesting and intriguing journey. Thank you very much, all the best. I'm Christoph Zielinski for CECOG, and I wish you to stay healthy and to stay safe. All the best. Bye-bye.